So today's is the last talk on in lymphoma pathology. We had wonderful talks before. This is going to be the talk on the diffuse architecture in nodal lymphomas. So the first few slides will be just a repeat of what you have already learned in previous talks of the lymphoma. But I thought for students' sake, I would just repeat it. So how do we make diagnosis of lymphoma and how do we classify? Now you have to see three things. One is architectural pattern. Other thing is you have to check for cellular morphological patterns. Then you do immunohistochemistry and check for antigenic characteristic of the tumor. And if it is possible, and sometimes you use molecular test also to make the diagnosis classification. Now on morphology, how do you see the abnormal architecture, and that is whether it is diffuse or nodular or follicular architecture. Nodular architecture is already covered in the last talk, and today's is about the diffuse architecture. In diffuse architecture, you have to see two things mainly. One is whether there is a single cell type. That means whether this lymphoma is composed of cells which are monomorphic, they are of same types, or whether the lymphoma is composed of something which is like a mixed cell type. That will be the cellular characteristic of the tumor. And when you combine all these histological features, which is actually gold standard for every histopathological diagnosis, and then you use immunohistochemistry or sometimes molecular studies to arrive at diagnosis. So what do you see in low power or high power? So you on low power you have to check the architecture. In architecture, you see for what is the status of capsule, what is the status of sinuses, what is happening to efferent and efferent lymphatics, and what is happening to the contents. How are the follicles? What do you see in paracortex? What is happening to the medullary cords? And then you see the morphological patterns. I already alluded that nodular and diffuse are common patterns, but there are some uncommon patterns like interfollicular pattern as well as sinusoidal pattern. You have to look at low power field. In high power field, you go and check for cytological details. Now in cytological details, what you see is what is the cell size, whether it is a small cell, whether it is intermediate cell or a large cell. And then you check whether this is completely composed of single type of cell, whether it is monomorphic or whether it is polymorphic. That means it has got mixed type of cells. And another thing you should check is whether this cells looks blastic or blastoid. So the grade wise, if you just categorize lymphomas into low grade and high grade, the low grade lymphoma, which majority of them are actually mature lymphomas. They have small cell morphology. They have a mature chromatin. They don't show you significant mitosis or apoptosis, and the MIB1 proliferation index or Ki67 proliferation index will be very low. They usually present with generalized lymphadenopathy and usually have a high stage disease. As opposed to high grade lymphomas, in high grade lymphomas, the immature lymphomas, that means plastic lymphomas, are always high grade lymphomas, but not all clinically high grade lymphomas actually immature or plastic. The mature lymphomas of large cells, intermediate cell size, can also be high grade lymphomas. They have high mitotic rate and proliferation index, and usually they tend to present with a low stage disease. So when you say blastoid or immature morphology versus mature morphology, what do you see in blastoid or blastic or immature morphology? What you have is actually a fine or homogeneous chromatin, and it will not have either it will have a nucleolus or it may not have a nucleolus, and these are considered an immature or blastic type of chromatin. You see this morphology in B and T lymphoblastic lymphoma. However, what you have to remember is in mature lymphomas, which are so-called blastoid variants of mature lymphomas, like mantle cell lymphomas, very rarely follicular lymphomas can also show you this kind of chromatin or morphology. As opposed to when you come to mature morphology, what you see in a chromatin is that it is clumped. Either it is clumped or vesicular, or it is hyperchromatic chromatin. And then we say that this is like a mature chromatin. So how do you judge the cell size? Now to judge the cell size, there are two, three things you can check. You check for the histiocytes and see the nucleus of histiocytes. So if the nucleus of histiocytes in this rectangle is there, if the nucleus of histiocytes is this, if the nucleus of the tumor cell is little larger than that, then it is a large cell lymphoma. If the nucleus of the tumor cell is similar to the size of the histiocytes or little small, then it is intermediate size. And obviously small lymphocyte like tumor cells are called small lymphomas. Now there is another thing you can check. You can even check the lymphocyte size. Let's say you have a mature lymphocyte, reactive lymphocytes in the background. If the cell size of the nucleus of the tumor cell is double the size of the small lymphocytes, then also it is like a large cell lymphoma. Now you may argue that in neoplastic condition, histiocytes and lymphocytes starts to look quite abnormal, and you may not judge their size. Their size might have been increased like small lymphocytes or even histiocytes which are reactive in the background. In such cases, you can take help of the RBC, because RBC size is almost like a small lymphocytes, and accordingly you can make the judgment for the size of the tumor cell. This is again small cells, intermediate and large cells. In small cells, usually you see small round lymphocytes, or you have cleaved small centrocyte-like cells. You have plasmacytoid small lymphocytes, or even monocytoid small lymphocytes. Whereas in intermediate cells, you have a lymphoblast-like cells or small cleaved Burkitt-like cells. In large cells, you have something like a centroblast and immunoblast-like morphology. So when now we are moving towards the proper lymphoma diagnosis. In diffuse lymphoma, as I already mentioned, you have to check for single cell type or mixed cell type. In a single cell type, you now go ahead and say whether it is small cell lymphoma having lymphoma having morphology which is small cell, or intermediate cell, or large cell. In a small cell lymphomas, we have already learned about it in the last talk, which is like a small lymphocytic lymphoma, so SLL, CLL, mantle cell lymphoma, marginal zone lymphoma, lymphoplasmacytic lymphoma, and these usually can show you diffuse morphology. But the SLL, CLL, mantle, and marginal can sometimes show you proper nodules or ill-formed nodules as well. And since they have been already covered in the last talk, I'm not going to cover them individually. In intermediate cell category, you have two tumors which you have to remember. One is a Burkitt lymphoma, which is a mature lymphoma, and another is a lymphoblastic lymphoma, which is immature lymphoma. And in single cell type, large cell lymphomas is a DLB cell is a prototype, and in T cell lymphoma, it is the anaplastic large cell lymphoma, or AL cell is the prototype. Now, what is a blastic or blastoid morphology? I already told you in theory, but now let us take some practical examples. So this A and B, two images, are actually has got blastic or a blastoid morphology. You can make out that the cell size is of intermediate size. The nuclear chromatin is quite fine and evenly dispersed, and you hardly see any nucleolus in this, as opposed to the mature lymphocytes in the background. And similarly, even in the B, that was A and this B, even in the B, the nuclear chromatin almost look like same. But these are two different cases, and we'll see how these two are different cases. This first one is actually a 9-year-old boy having a lymph node, and this boy also had a mediastinal lymph nodal mass. So what you see on this complete scanner image is that you don't see any nodularity, you don't see any follicle in this. So it looks like it is a diffuse morphology or a diffuse pattern. And you go on to little high power when you start to see that the cells are here like looking quite monomorphic. Now, in order to see the nuclear chromatin, you have to go on one high, and you start to see that again, whatever I said, that this looks quite a blastic or a blastoid chromatin, wherein the nucleus is round, cell size is intermediate, and the nuclear chromatin is quite evenly dispersed. Then you have to go ahead. Now, since this is a 9-year-old, you will think more of in terms of lymphoblastic lymphoma, obviously. You will not think of any mature lymphomas in this case. So you go ahead and do the immunohistochemistry accordingly. This tumor was CD20 negative, CD3 is nicely positive. It was TDT diffusely positive as well as CD34 positive. And then it was also positive for CD10, which is also called common leukocyte antigen or CALA antigen. And it was MPO negative. Because we are thinking of blastic morphology, one would have to think of even something like a myeloid neoplasm involving the lymph node, and MIB was quite high. So this is a T lymphoblastic lymphoma. So the case A, which has got this plastic or blastoid morphology, is actually immature lymphoma, T lymphoblastic lymphoma. Now we'll come to the SB. SB is actually from true cut biopsy in an elderly male who's got a generalized lymph node. So here the clinical scenario is a little different. And you see again that the chromatin or the cell morphology is similar. It's an intermediate site cell having quite dispersed chromatin in the cells. The cells nuclei are quite round. There is very little bit of nuclear pleomorphism here, but mostly they look quite monomorphic. And then you accordingly go and do the IHC. So CD20 is diffusely positive. That proves that it is a B cell lymphoma. Then you see CD3 and CD5. You always compare CD3 with CD5 because when CD5 starts to come in B cell lymphoma, it is a very significant thing, even though it is a T cell marker. So here you can see in CD3, the darkly staining cells are actually reactive T cells, small reactive T cells, and in between there are quite these blue areas are there, wherein the tumor cells, the actual cells of interest, are not taken up the CD3. But you look at the CD5 as is in comparison, there are these darkly stained small lymphocytes you can make out even in this low power, but there is something happening in between. It looks quite rather weakly brown. So I'm suspecting on the low power that CD5 is weakly expressed as opposed to the CD3. When you go on high power, is definitely that there is a weak expression of CD5 in within the cells of interest, and the darkly staining cells are actually reactive T lymphocytes. And you obviously, since CD5 was positive, it was CD23 negative, and you then go ahead and do cyclin D1 to confirm whether it is actually a mantle cell lymphoma. So cyclin D1 was diffusely positive. Even we did SOX11, and SOX11 is also positive, proving that this is actually a mantle cell lymphoma. And you look at the MIB1, MIB1 is quite high, almost 80%, 80 to 90%. So this is a blastoid mantle cell lymphoma. So what we learn from this, that when you have this kind of morphology, according to the clinical the history, you have to rule out either a blastic lymphoma, which is like a lymphoblastic, or a blastoid variant of a mature lymphoma. For blastic and blastoid morphology, as I already mentioned, for lymphoblastic lymphoma, you do TDT 34 and CD10 markers along with CD20 and CD3 to prove that it is a blastoid mantle. In the last case, which we did cyclin D1, SOX11. Very rarely, a follicular lymphoma can transport, the low-grade follicular lymphoma can transport you to something high-grade lymphoma which has a blastoid morphology. In such cases, you will have to do follicular markers, which are like CD10 and BCL2, to prove that it is a blastoid variant of follicular lymphoma. And sometimes lymph node can be involved by extramedullary myeloid cell tumor or myeloid neoplasm. In such cases, you will have to do additional markers like CD43, MPO, or CK to prove that it is a myeloid marker. Obviously, you need to prove that it is not a lymphoblastic lymphoma. Most of this blastic or blastoid morphology tumors are actually intermediate sites lymphomas. Now, this is a very famous starry sketch pattern. Everybody likes it, students, and we always associate with Burkitt lymphoma. Yes, this case is a Burkitt lymphoma. It looks because it's so monomorphic and intermediate site cell with evenly dispersed this histiocytes. So that's what gives it a starry sketch pattern. But starry sketch pattern is not only seen in Burkitt lymphoma. Any high-grade lymphomas can show you a starry sketch pattern, be it a lymphoblastic lymphoma or a high-grade large B-cell lymphoma, can also show you starry sketch pattern. This is a 39-year-old male. This is actually not a lymph node, but it is a jejunal tumor for this lymphoma. And you see that it is, again, even at the extranodal side, one can make out that this is a diffuse morphology. You go on high power, and now you check, it looks quite monomorphic. That much we can make out in this image. And there are actually in between dispersed, there are histocytes containing tingible body macrophages. That gives actually this tumor a starry appearance. And you see on little high power, you can see now that the cell size is intermediate. there are one to multiple nucleoli in this nuclei. But what is happening to the cell borders? You can see that the cell borders are quite angulated, as if these are the floor tiles which are being set against each other. That's how it looks in this tumor. And again, in another high power, you can make out that morphology still there, the angulated cell borders, the intermediate size nuclei with one or multiple nucleoli, and then in between there are this histocyte containing the apoptotic bodies. So we are suspecting Burkitt lymphoma. It's a clinical setting is also correct. A young adult with jejunal or ileocecal mass, and so you are doing IHC to confirm it. So CD20 should be positive. It is diffusely positive. CD3 is negative. It is CD10 positive and BCL2 negative. So it is fitting into a diagnosis of Burkitt lymphoma. But you have to go ahead and do something more to prove it. CMYC is diffusely positive. CMYC has to be diffusely positive. More than 90% of the cell or almost 100% of cells should express CMYC to call it a Burkitt lymphoma. Provided BCL2 is negative also. And Ki67 is very, very high, always more than 95%, almost going up to the 100% in Burkitt lymphoma. Sometimes you have a morphology which is not so clear because of the poor fixation, or tumor itself doesn't have that proper histology. Then you can take do the additional markers like CD38 and CD34. Burkitt lymphoma differently expresses CD38 and CD34. It is negative. That also then proves that it will be a Burkitt lymphoma. So this is what I was alluding to, that this is this tile-like morphology of the cytoplasmic border. They become quite angular, and at the very typical clinical scenario like cervical or mandibular large mass or right iliac or ileocecal fossa, having this typical morphology and typical immunophenotype which I already mentioned, you can make the diagnosis of Burkitt lymphoma. So we have covered intermediate cell size tumors, Burkitt and lymphoblastic. Then we'll go to now large cell lymphomas, which are single cell type. So the most prototype is actually DLB cell and its variant, which has got by name itself, it says diffuse morphology. And there is another large cell lymphoma having monomorphic morphology, which has got diffuse monomorphic morphology, is anaplastic large cell lymphoma. So again, the definition of DLB cell, as I already mentioned, how do you make it, like, when do you say large cell or intermediate cell? So by definition, it is a neoplasm of large B lymphocytes, and it has to exceed the size of the nucleus of the normal macrophages, or the twice the size of the normal lymphocyte, and has to have a diffuse growth pattern. Now you can have a different morphological variants in DLB cells. So first is that centroblastic. What you see in a centroblastic is a large nucleus having a vesicular type of chromatin, but you'll have a nucleoli which are towards the periphery. Usually you have 1, 2, 3 nucleoli which are towards the periphery. Then you have immunoblastic morphology, wherein again it is a large nucleus, vesicular chromatin, and a large prominent nucleolus, single, you will see. That is a immunoblastic morphology. In a plasmablastic morphology, you again have a single, in a single large nucleus, you have single nucleolus, which is a large, but you tend to see this paranuclear half, and the nucleus is little pushed to the side, so it gives you a plasmacytoid appearance. Now, you can have anaplastic cells which are having nuclei which are multinucleated cells, which are start to call them anaplastic variant, which the nuclei can resemble like a centroblastic cells, or the multinucleated cells which has got a nuclei which are having an immunoblastic morphology. Less common morphologies which have been described in DLB cell are spindle cell, rosette, myxoid stroma, or signate, or fibril projection. But remember that whenever you have such very rare and less common morphology, they will never have a pure morphology of spindle cell or pure myxoid stroma or signet ring morphology. Somewhere this tumor will always have a typical morphology of large B-cell lymphoma. So what is recommended by WHO also, that once you have something which looks like a large B-cell, diffuse large B-cell lymphoma, you try to categorize into two types. One based on the cell of origin. One is whether it is coming from a germinal center, or whether it is post germinal center or activated B lymphocyte like say tumor. So you, for that, the most common or the most popular algorithm which is used is called as Hans algorithm, wherein you use three markers: CD10, BCL6, and MMM. The cutoff for the positivity for these markers is actually 30% or more. So if any of the marker is positive in 30% or more cells, then you consider that as positive. So you start with doing CD10 in Hall's algorithm. When CD10 is positive, it doesn't matter what is positivity for BCL6 or MUM1. You directly place it into the germinal center B cell like phenotype. If the CD10 is negative, the next marker you do is BCL6. If BCL6 is negative, then you directly put it into non-GCP, like you does not even need to MUM1. But let's say CD10 is negative, BCL6 is positive, then you have to go ahead and do the MUM1. If the MUM1 is positive, you say it is non-GCP type or activated B cell type. If MUM1 is positive, then you call it non-GCP. If it is negative, then you again call it a GCP like phenotype. Now there are other algorithms people have tried. The Hans algorithm is more popular because these immunostains are available in most of the labs. There are immunostains which are available in these algorithms are not commonly available in most of the labs. So even in fact in our lab we use Hans algorithm only. Dr. Natkunan had proposed a very simple algorithm just using one marker, which was LMO2, and if LMO2 is positive, in I think the cutoff is 30%. If more than 30% is positive, you call them GCP. If it is anything less than that or negative, then you call it a non-GCP like. So you always must have heard that in molecular subgroups of DLB cell, people call it double hit or triple hit, and something then we say double expressor. So double hit and triple hit actually based on a molecular studies wherein you prove that the tumor has either CMYC or BCL2 translocations, or if there is a CMYC or BCL2 translocation, then you call it double hit lymphoma. In addition, if it has got BCL6 translocation, then you call it triple hit lymphomas. Now this is based on purely by doing fish studies or any other molecular studies to prove that it is a translocated tumor. These tumors are mostly GCP like tumors, and these form only 3 to 6% of all the diffuse large B-cell lymphomas. as opposed to this double expressor type. This double expressor type actually is based on a immune expression. So if you have tumor which is c-MYC positive and BCL2 positive, then you call it a double expressor phenotype. These are mostly fall into ABC or non-GCB like tumors, and 25 to 30% of the DLB cells are actually double expressor DLB cells. The cutoff for positivity here to call something double expressor, for c-MYC the cutoff is 40% or more cells, and for BCL2 it is 50% or the more tumor cells. So immunohistochemistry, to prove that this is a large B-cell lymphoma, most commonly we do CD20, but sometimes you might need to do another markers like CD19, CD79A, PAX5, CD20 is not so commonly available, but it is also marker. Most of these tumors can show you some heavy chain restriction. IgM is most common in that. Sometimes they will express plasmacytic markers CD38 and 138. CD30 can be variably positive, and up to 10% of the tumor do express CD5. In such cases, you might have to go ahead and do cyclin D1 or SOX11 to prove that it is not something we are dealing with like a blastoid or a pleomorphic mantle cell lymphomas. So the panel which is recommended by NCCN for to make any diagnosis of DLBCL is CD20, CD3, CD5, CD10, BCL6, MUM1, BCL2, MYC, and MYB1. So this panel covers your Hans algorithm as well as gives you an idea whether the tumor is double expressor or non-double expressor. And then certain markers you can do in additionally like cyclin D1, kappa lambda, CD30, CD138, Iberish, and HH3 in appropriate situations. And some of the cases which I am going to show have used those kind of markers. So this is one of the cases where this is a lymph node biopsy in an elderly patient, and this is a true cut biopsy actually. But even in true cut, one can make out that this looks like a diffuse proliferation. You go on high power and you start to see that it is quite pleomorphic, or it has got variation in the nuclear size. There are given some very large looking cells here and there, and some intermediate sized cells. So the very large looking cell, intermediate sized cell, it looks like pleomorphic, and I mean obviously one start to think that it could be a DLB cell, and then you start to do the marker. But this tumor had a brilliant CD20 positive, it was CD3 negative. It showed CD5 positivity and cyclin D1 positivity, and it had got very high MYB1 index. So this is nothing but it's a pleomorphic mantle cell lymphoma. So before you jump to say that something is a DLBCL, you have to look at the morphology carefully, and you will keep in mind that DLBCLs can be confused for pleomorphic mantle cell lymphoma, and pleomorphic mantle cell and DLBCL have very different prognosis, as well as they are treated very differently. So you have to keep that in mind before you go to make diagnosis of DLBCL. Now this is the latest WHO classification for DLBCL NOS and its different types or subtypes. Apart from DLBCL NOS, there are 17 different categories are there, and I don't think we can go into details of everything. So there is a comparison with the old classification here. Some of the entities are remaining this; they have kept same as those entities. Some of the new entities have been added to the group, like fibrin-associated large B-cell lymphomas or fluid overlaid associated large B-cell lymphomas. And the notable difference is made in this category of the mediastinal lymphoma is that when we used to say B-cell lymphoma unclassifiable, which features intermediate between DLBCL and classical Hodgkin's lymphoma, now they directly call it a mediastinal gray zone lymphoma. So DLBCL, as I said, is the most common of the all NHL. It is almost 30 to 40% of the all NHLs. It is a heterogeneous group. Mostly it occurs in adults, but remember that it does occur in children as well. It most arises de novo, but transformation from low-grade lymphomas like CLL, SLL, follicular, marginal, and NMPHL have been described. It is most commonly seen in nodal sites, but 1/3 cases can occur at an extranodal sites. Bone marrow involvement is seen in almost from 11 to 27% of cases. And you can have a discordant morphology when the bone marrow is involved. What do you mean by discordant morphology? Is that the tumor in the node is a large B-cell lymphoma, but when you do the bone marrow for staging, you will see that the marrow is involved by actually a low-grade lymphoma, like a follicular lymphoma. That is how the discordant morphology you may get in these tumors. Now, this is